afternoon. This is Dr. McDaniel. Today is Monday, Memorial Day. Happy Memorial Day. It's a gorgeous, beautiful day here in New Jersey. I hope that's the same where everyone else is joining. As most people know who follow the publications and the presentations, I had a wisdom tooth pulled for a bad cavity a couple of days ago, and I'm still in quite a bit of pain today. I'm trying to keep up with the pain medicine, but I'm not doing such a great job today. So I'm going to finish up on preterm delivery, and I'm going to try to make it kind of quick since I've got a bad headache everywhere. So the preterm delivery, everyone can go back to the detailed presentations I started on Thursday, which was May 22nd. So the 22nd to 23rd, it may have been May 23rd. So it was Thursday, Friday, Saturday, Sunday, and today's the last day. Today's the 27th, so it was the 23rd. For the details, in brief, preterm delivery is any delivery that occurs before 37 weeks of pregnancy. The expected due date is always set for 40 weeks. Full term is 3 weeks earlier up to 2 weeks later. So under 37 weeks is preterm delivery. An early preterm delivery is 28 to 34 weeks, and an extremely preterm delivery is under 28 weeks. There are a variety of reasons why someone could go into preterm labor and subsequently into a preterm delivery. Poor nutrition, poor health, those are always cofactors. Chronic smoking, frequent alcohol use or abuse is a common factor. Drug use such as cocaine, chronic medical conditions, hypertension, for some people diabetes, and birth defects or anomalies of the cervix that weaken it, or multiple surgeries of the cervix, and also uterine anomalies such as the uterus having a wall, a septum, or having two uteri or a smaller uterus. Any kind of aberration on the normal theme, those can all affect the capacity for the uterus to hold a full-term pregnancy. And of course, multiple gestations. So if someone has twins or a higher order pregnancy, that's a definite increased risk for preterm labor, preterm delivery, and infection and trauma. If someone falls or hits the uterus and the placenta starts to separate, that of course will cause preterm delivery. So multiple reasons, a lot more detail I think I have on that presentation. Once someone is at a risk or perceived to be at a risk for preterm delivery, then evaluation can proceed. One evaluation would be an ultrasound or a sonogram of the cervix to see if the cervix is getting short, less than an inch or 25 millimeters, or if it's starting to open, which is funneling. And a swab can be performed to look for the protein, fetal fibronectin, which is the protein that connects, that kind of glues the lining of the amniotic sac or the bag of water to the uterus. That's the fetal fibronectin. And evidence of that protein being present increases the risk that that woman will go into preterm labor and potentially delivery within 7 days. Lack of that protein gives you about a 2-week confidence level that nothing will usually occur. In addition to that, tachometer, which is putting a monitor on to see if there are actual adequate and frequent contractions that perhaps the woman is not perceiving, can be performed. Bed rest and hydration will help a teeny bit, but not a lot. If someone wants to try and stop active contractions, active labor which would lead to delivery, then medication. Asthma medications such as terbutaline or ridodrine are given. The most popular, the most common, pervasive is magnesium sulfate. Magnesium sulfate will definitely slow uterine contractions, decrease the strength and the force of those contractions, which are leading towards preterm labor and delivery. And it's also thought that magnesium sulfate helps decrease the risk of neural problems if the woman does deliver early. In addition to that, corticosteroids are given, usually one shot if the woman is under 34 weeks, to help speed up lung maturity and help protect liver and brain function. And if the lady does continue to go into preterm labor, if the pregnancy is under 32 weeks, then she's often recommended to have a cesarean so that not a lot of pressure can be put on the fetal head and potentially cause bleeding into the head or intracranial hemorrhage. If she's over 32 weeks, then a vaginal delivery is often allowed, given everything else is normal. And then the concerns for preterm labor, preterm delivery are going to be if there's lung maturity. If the labor is stalled, then an amniocentesis, where a little bit of fluid is pulled out of the bag of water, can be done to test for lung maturity. If there isn't any time, then the concerns with preterm delivery are going to be the concerns due to the organs that are still continuing or finalizing their development in the third trimester. That's going to be the brain, neurologic aspects, so obviously brain development and vision, the lungs for breathing, pulmonary problems ensuing from that, and then liver, GI organs, which are intestinal development and the liver development. Those are the primary concerns, and usually the main problems that ensue if a baby's born early. But stalling for at least 48 hours once the corticosteroid is given will often help alleviate or mitigate or decrease those prominent factors. So that's going to be a wrap on the preterm labor, preterm delivery information that started on Thursday, May 23rd. There's more detail on each of those days. This is in response to a viewer question about her daughter who had 3 preterm labor deliveries and lost those 3 pregnancies. So I hope that provided some insight and information for the viewer and for anyone else who's interested. Like I said, I'm still recovering from the dental work I had, so I have a bad headache today, and I hope I was able to speak clearly and not sound, I feel like I'm a little bit draggy. But if people could understand. Thank you very much for watching. Please check out the YouTube channel. It's also called GYN Corner. Have a great rest of Memorial Day. Be back with you tomorrow. Thank you. Oh, there's the button. Hold on. Technical difficulties.